Hello, everyone. Welcome, welcome. And for those of you that have been here listening to me speak, this is probably sounding redundant, but I'm very excited to be welcoming you to our first collaboration with AMSA, American Medical Student Association. So tonight's event is technically hosted by PsychSign, which is Psychiatry Student Interest Group Network, which is a lovely branch of the American Psychiatric Association, a student interest group network that is, of course, interested in psychiatry. So it's obviously context clues, but we are excited to present this. Madeline and I, who will be here shortly, we are the co-chairs of Wellness and Burnout Prevention. And so we like to have these little mental health Mondays where we can, which are opportunities to hear from speakers across the medical body that can be here to really shed light into some important concepts for us to keep in mind, both as future clinicians and students, but also being trauma focused, right? Being really centrally minded to this idea of, yes, as psychiatrists, we are of course trauma focused as potential future psychiatrists, but also as medical students, no matter the specialty that we choose, being trauma minded and being just aware of our patient body and some of what they might have experienced and the stressors they might have experienced in their lives and how that impacts how they show up in the therapeutic alliance is so important. So that is one of the many reasons why we have hoped to form this cross collaboration between AMSA and PsychSign, because no matter again the specialty, which of course much of the American Medical Student Association is interested in all specialties, these students that comprise of that student body. So here at PsychSign, obviously more oriented towards psychiatry, and so in hopes of this cross work, right, we're hoping to shed light onto the importance of that exact concept, that therapeutic alliance being strong and creating a place of safety and trust, no matter the specialty that we choose, because this is just a part of what it means to take that Hippocratic oath. And especially in a time like this, which does not take much of me going on about. I think we all know what that means. Given where we're at in the state of the world, it is so important more than ever that we are equipped to be trauma informed. So without further ado, I'll just briefly say, of course, I'm Danya. So for those of you who don't know, but co-chair of PsychSign Wellness, and my lovely Madeline, who is also our other co-chair, who I'll let her say hi here as well. So I'm going to quickly remove my spotlight and let her say hi real quick.
Hi, I apologize for being a little late. I'm super excited to learn from you, Dr. Brown, and just looking forward to this meeting. So thank you for being here.
Thank you so much. That's wonderful. We're glad always to be here together. So without further ado, tonight's discussion is surrounding trauma-informed care clinical skills. These skills span communication skills and also physical exam skills, essentially how to be a trauma-minded clinician in this space. So there is truly no one better than Dr. Taylor Brown. I mentioned before starting this recording, but I think it's important for everyone to know that she is truly a special person. We have a special relationship that I've felt really, grateful for. Not only a leader in trauma-informed care and trauma-informed medical education, but just someone that you will, definitely want to keep in your life and in your circle as a mentor. So I feel really grateful. We feel really grateful to have her here today. She'll, of course, spend some time introducing herself and getting started on our wonderful discussion this evening. But I think what, for me and for Madeline and I, what feels the most important to share is that she is an expert and leader in this space. And coming from an emergency medicine background, I think it's even more captivating, right? That she's able to bring in that perspective of emergent trauma-focused care and really has that voice in the space of, I know I keep repeating this, but no matter the area of medicine that we choose to practice, the time is now to know these skills. So I'm going to hand the totem pole off to Dr. Brown, and thank you so much again for being with us.
Thanks, Danya, for such a generous introduction. I'm excited to share tonight about trauma-informed clinical skills. As Danya mentioned, I'm Dr. Taylor Brown. I'm an emergency physician at Beth Israel Deaconess Medical Center in Boston. I've been passionate about trauma-informed care since I was a medical student, and that's when I started teaching on this as well. In terms of what we'll go over tonight, I'm an emergency physician. I'm not a psychiatrist. I don't practice trauma-focused therapy, but I do practice trauma-informed care as a universal precaution with all of my patients. So we'll go over some of the background of why trauma and considering this in our patients is so important. We'll do a brief introduction of what trauma-informed care is, but then we'll get into actually what it looks like practically when I'm working with patients. How am I communicating with them, and then how I'm adapting my physical exam skills. I will ask for some participation. I know this is an evening for most of us, and maybe you guys are tuning in while you're making dinner or studying or doing other things. So we'll have a variety of ways to participate, but I think that's how you get the most out of the content. I have no disclosures, but I do always start my talks with a content advisory. The topic can be heavy to discuss. I won't go into any, detailed descriptions of traumatic events, but if at any time the content feels activating to you, please feel free to go off camera, take a break, however you need to take care of yourself, and then rejoin us when you feel able. All right, you guys will hear me say the word trauma about 500 times throughout this presentation. So I just want to make sure we're all using the same definition. As an ER doctor, a lot of times when I say trauma, my colleagues think about blunt or penetrating. Was it a car accident or a gunshot? Which could be traumatic events, but when I say trauma, I'm focused on the Substance Abuse and Mental Health Service Administration, or SAMHSA, their definition of trauma, which uses the 3 E's. It's going to be some event that happens in an individual's life. They're going to experience that event as harmful or life-threatening in some way, and then it's going to have some effect on that person's well-being. When we use that broad of a definition, we see how many things can be incorporated into that. It might be that car accident that I mentioned. Certainly, surviving community violence and a gunshot wound is a traumatic event. It can be interpersonal, like violence or intimate partner violence. We can think about societal things like natural disasters, pandemics, war, terrorist attacks. But it also comprises, everyday discrimination as well as structural traumas like racism, sexism, transphobia. When we try to think about how trauma impacts health, the field is really based on the landmark study called the Adverse Childhood Experiences, or ACEs study. And if you've heard of this study, great. If not, I'll go over it briefly. Back in the 1990s, Kaiser Permanente looked at their population and looked at a couple potentially traumatic events in early childhood, which became known as the ACEs. And it focuses on 3 categories of abuse, neglect, and household dysfunction. And I want to acknowledge these are not all of the ways that individuals experience early childhood adversity, but these categories are the most well studied. The other caveat of this study is that this is a relatively privileged population. The individuals were predominantly white, predominantly middle class, and they were all insured because it was through the Kaiser Permanente system. Even in that population of relative privilege, a majority of individuals had experienced some early childhood adversity. About 54% had experienced at least one ACE. They also found that ACEs cluster. If you experience one, you're more likely to experience additional. And then really critically, they found that there was a dose-dependent relationship between ACEs and negative health outcomes as an adult. So the more adversity you experienced in early childhood, potentially the worse your health was as an adult. For some examples of that, the highest risk category is adults who've experienced 4 or more ACEs. When you compare that group to adults who've experienced no ACEs, adults with 4 or more are 12 times more likely to attempt suicide. They're 7 times more likely to have a substance use disorder. And they also have twice the risk of diseases like cardiovascular disease and cancer. When we talk about the adverse childhood experiences, it's also important to know that there are positive and protective childhood experiences too. And what really matters for individuals, we think about this balance. So if you have a lot of nurturing experiences in early childhood, it can offset some of the negative ones you have. But if you have a lot of early childhood adversity, sometimes that overwhelms the coping mechanisms and, folks get stuck in this state of kind of dysregulation. Additionally, chronic stress, especially in early childhood, can alter individuals' neurodevelopment. So if you're someone who experiences a lot of chronic stress in your early childhood, you're going to have fewer total neurons develop in your brain and fewer neuronal and synaptic connections, which is then going to lead to abnormal structures and function of your brain networks. And this is kind of a new and really impactful field developing in neurobiology. But what we see in patients is that impacts how they behave and interact with healthcare. So I introduced this concept of the window of tolerance. And you can see in the gray in the middle there, when folks are in the window of tolerance, they're able to emotionally regulate. If someone bumps into them, no big deal. They're able to engage in their healthcare if you're making recommendations or tough choices. Um, but individuals who experience a lot of adversity may also experience emotional dysregulation. So that window of tolerance is going to be smaller, which means that the same stimuli that someone with a larger window of tolerance may be able to handle may be extremely activating for an individual with a smaller window of tolerance. They may go into this hyper aroused, like fight or flight state where they're agitated, they have overwhelming emotion, but they can also shut down, become numb, disconnected, kind of dissociate. I think another thing that's really important to mention when we talk about this emotional dysregulation is people learn these behaviors in an environment where it's adaptive. It is a survival mechanism. If there's constant threat in your life, you want to easily be activated into fight or flight. But when those behaviors translate into, our clinical environment, they seem incredibly disruptive to us, and we don't understand why a patient's acting this way. The other really important thing is it is impossible for us to predict what may activate a person to go in and outside of their window of tolerance. It can be a sound, a smell, a sensation, a negative emotional interaction with someone. We just don't know. And that's why I practice trauma-informed care as a universal precaution with all patients. So we talked about kind of the doom and gloom portion of how experience of adversity can really directly impact the patient's health and how they interact with healthcare. And this is the part where we learn what we can actually do about it to intervene. So trauma-informed care, or TIC, is a harm reduction theory that was developed by SAMHSA. And it centers around these 6 principles: safety, trust and transparency, peer support, collaboration, mutuality, empowerment, voice and choice, and cultural, gender, and historic acknowledgments. Now, this seems very, very high level to just kind of list the principles out. So I'll give you kind of an example, because TIC is all about shifting, instead of asking a patient, what's wrong with you? Why are you acting like that? It asks us to instead shift our focus to something like, how has what has happened to you in your past impacted you? An example I like to use is considering maybe a patient who's undergoing a routine procedure like a hysterectomy, having the uterus removed. Very common procedure. If a patient is expressing a lot of fear about that upcoming surgery, it's very easy to default to something, say you're the OBGYN performing the surgery. I've done this hundreds of times, thousands of times. There's nothing to be worried about. But if we don't ask about the patient's experience, we're not going to understand why they're concerned. If, for example, they knew someone who had a bad complication from this procedure, that's a completely different conversation than maybe someone with a history of trauma that is afraid of undergoing anesthesia and being unconscious in a room of strangers. And if we don't ask that follow-up question, if we're not curious about how what's happened to someone has impacted them, we're going to have very different conversations with a patient. And if we're not getting at that root cause of the fear, maybe they don't show up for the surgery. Maybe they just cancel it. or maybe they have an extremely difficult time with the procedure and the aftercare and the hospitalization. I'll pause here as we're about to move into, I've given you kind of the broad overview of the theory, and we're going to move into how we start to apply this to our clinical interactions. I'll ask Danya to help me monitor the chat since I'm screen sharing, and I'll give it a moment to see if anyone has any questions.
Thanks so much. Yes, guys, please feel free to enter in a question or a thought into the chat. No worries if there's nothing at this time. I think I have a quick thought, surprise, surprise. I want to mention that something that I think is really mindful and or helpful to hear even at the onset of our discussion this evening was how we view trauma in a different lens depending upon our different perspectives and backgrounds and what we've been exposed to. So I think it's really important for us to think about, as we're speaking with patients and we ask broad statements like trauma histories, right? What exactly are we welcoming in that space? But yeah, just a thought. But I think we're good to keep going.
Perfect. So for this next exercise, I'm going to show you guys a video that we developed with some colleagues at Brigham and Women's Hospital with an interdisciplinary team. The video is quick, it's only about 3 minutes. It's going to start off with a patient interaction that I would consider is kind of the standard of care. And then it's going to re-demonstrate the conversation using a more trauma-informed approach. And you'll see at the start of the video what kind of pillar of TIC it's hoping to highlight. So as you watch, my ask to you all is that you pay attention to the trauma-informed interaction. And then afterwards, you can either respond in the chat or unmute yourselves if you want to speak. And we'll share some of the things we noticed from the video that were trauma-informed communication skills.
Hi, Carol. So we're getting ready to send you home today and want to go ahead and coordinate for your follow-up care that you'll be getting once you get home from the hospital. Okay. Your family mentioned your primary care doctor as the person to follow up with, so we'll go ahead and make contact with their office today.
I just saw my primary care doctor. Do I have to go back there?
Yes, we want you to get your labs rechecked, your blood pressure, your kidney function. We want that rechecked soon.
Okay, you said you were going to call?
Yep, we'll go ahead and call, make an appointment today, and we'd also like you to speak with a social worker too. You mentioned some concerns about your husband yelling, and I'm worried that maybe you're scared of him, and I might want you to talk with Elder Services just to make sure that you're safe at home.
I already spoke to them. I don't want to do that again. Are you going to call my PCP and tell him about this? I'm really afraid he's going to be disappointed in me, that I don't want to talk to Elder Services and that I don't do all the things he tells me to.
Hi, Carol. So you're ready to go home. We're going to coordinate with your outpatient providers to make sure that you have care set up for when you leave the hospital. Your family mentioned your primary care doctor as the person to follow up with, so we can go ahead and make an appointment with that person.
I just saw my primary care doctor. Do I have to go back there?
Well, we do want to get some of these labs rechecked soon, but it sounds like your primary care doctor is not the right person to follow up with.
Well, I just saw him, but I've also been seeing this other person that my friend from church told me about a few months ago, and I finally got an appointment. She's a nurse practitioner, I think, and she works with people like me. I find her really helpful. Can you call her instead?
Well, thank you for telling me about her. It's important that we have a care plan set up for you, and it's critical that your input be included. So yeah, we can definitely go ahead and make a phone call to her.
Great, thank you. Can you also not tell my family? They don't know about her, and I don't want them to make me stop seeing her. She's really helpful, and she didn't make me talk to the Elder Services people like my primary care doctor did. Also, My husband made me stop seeing a holistic provider a few years ago. He said that she doesn't have the training that a doctor has and so couldn't be respected. Ever since then, he's been really involved in all of my medical appointments and decisions.
Carol, it sounds like that's been really hard. Would you be willing to talk to a social worker about some of these issues that you're describing, some of these dynamics with your husband and with your care, so that we can come up with a plan that you feel comfortable with?
You know, that would be really great. This feels really complicated.
All right, a thank you to our colleagues and their acting in the video series. I'll ask Danya for help again monitoring the chat, or if you feel confident to unmute and share, what are some of the trauma-informed behaviors that you noticed in the video?
Hello, my name is Monica. Hi, Dr. Brown. Thank you for
Hi,
this.
Monica.
Thank you for your time. I'm an ING from Mexico. So what I noticed in the discussion is mainly the doctor was very open to discussion, and she was very observant of the reluctance on the patient. Even if she wasn't saying it with words, she was expressing with her facial expressions that something was going on. And so the doctor was able to catch on that and ask if of her preference first, instead of just giving her directions as such.
Yeah, I love that reflection. She kind of notices the patient hesitation, and I'd almost argue she starts off the conversation the exact same way, not particularly trauma informed, but notices the patient pause and then kind of redirects to include the patient in the discussion a little bit more. Awesome. Thank you so much for sharing.
Thank you. We have a few wonderful comments in the chat. So Sebastian shared that the provider seemed curious and open to better understanding the patient's lived experiences instead of simply seeing the patient's apprehension and moving on with her instructions. She took the time to reflect the attitudes back and say, "It sounds like your primary care provider might not be the right person." We also have a thank you, Omnia, about respecting patient autonomy and that there was active listening involved.
Awesome. I love that. Yeah, you guys are picking up on, instead of, in the first example, she tells the patient what the follow-up plan is versus suggesting one, hearing the hesitation, and then working with the patient to establish a better follow-up plan. Awesome. Thank you guys so much for the first activity. The next thing I want us to do is consider a case with a couple more discussion questions. So I think we're a fairly small group tonight, so it might be easiest if we just stayed in the large room together. And then we can discuss some of these questions, and we'll keep the same format of both as you're able to unmute, and then we'll also think about the chat as well. So I'll read through the first scenario, and then I'll give everyone a minute or two to reflect. We're going to think about Wanda, who comes into primary care, and she's coming in with palpitations that she wants to get evaluated. When you ask her about the time when she first noticed the palpitations, she tells you that the first time she remembers it happening, she was doing dishes. There was a song on the radio, and it reminded her of an ex-husband, and they did not have a healthy relationship. And that's the first time where she noticed the palpitations. So the first thing we're going to think about together is, what do we say when Wanda shares something so impactful like this with us? We're going to think about, are there any next steps we are going to take in that moment? Are there any resources we're going to offer her? And I know that everyone's still in the training phases of their career. So then we're also going to think together about how we're sharing this information with the team.
I can start with how maybe I would initially respond, if that's okay.
Sure.
I mean, I just know that the basic maybe starting position would be saying like, oh, well, thank you so much for sharing this with me. That sounds really hard. Just kind of saying that statement, um, acknowledging that it probably was hard to share that moment and that it was hard to go through that experience.
That's great. That's a great response.
Well, I also feel very strongly about like what Madeline's saying, like turning towards the moment, because I've found, and even in my own experiences, like being a patient, just that a lot of times when you mention something like this, it can be kind of washed over and like right and going straight back into like the clinician hat of like, okay, so let's just, palpitations, oh my God, like let's prescribe you, instead of like, what, let's be with this. And I think even like a quick pause, and offering to, listen if there was more, I think can go a really long way. Curious, other thoughts?
Yeah, kind of going off that, letting like not moving on too fast from the subject and in terms of next steps, rather than just like offering resources, I think it would be wise to kind of just see like, because it was 10 years ago, see if, she's done anything regarding the incident, where what she did in these past 10 years to now, because for all we know, she may have done therapy. We don't want to assume that she hasn't done anything. So just start an open dialogue.
You guys are awesome. Maybe it's because everyone's psychiatry interested too. You're leaning into what the patient's telling you versus, I think there's a lot of even attending physicians who, when this comes up, if we don't talk about it, if we're not trained on how to respond to disclosures of trauma, it can be awkward. It can be uncomfortable. You know, I haven't explicitly mentioned in this talk, but it's also important to consider our own experiences. Maybe a patient says something that reminds us of experiences we don't like to talk about, and it's uncomfortable. So many clinicians would shy away from this and get right back to the palpitations and start a cardiac history. But I think you guys, all of your inclinations are correct. I've heard, we're making empathic statements towards Wanda. No one has used any kind of judgmental language, which is also appropriate. Um, and we're checking in. We're checking in about this thing before we move on. Would anyone ask any specific follow-up questions?
Hi. I think I would like to ask the patient if there's anything that she does in that moment when she has those palpitations to cope with it. Anything like breathing or any relaxation techniques that she might want to use in that moment. Or if she's aware of any techniques like that, and if not, then maybe we can discuss something like that for her to not just pharmacologically, but also in terms of what she can do in that moment to alleviate her symptoms.
That's awesome. You're foreshadowing the end of the talk. Thanks for sharing.
I'd like to bring attention to Rahi's comment, actually. I would love to, I'm gonna put you on the spot. But I think not assuming, so he mentioned not assuming that she hasn't had therapy or any type of background in that. I think that's something I hadn't thought about. I think that's really important that we, maybe even inquire like what her history is, right? Or if she has ever had any experience with that. Just because we again don't want to assume. So I don't know, Rahi, if that would be one of your questions, but I really enjoyed that comment.
I guess I was more thinking of it from like I was thinking of the videos we just watched and how like the first clip of what not to do seemed very like paternalistic in terms of like telling the patient what to do, and like I think going straight to like, oh, here's resources for domestic abuse and just throwing resources at the patient is kind of in line with that paternalistic side of medicine where you just kind of tell the patient what they should do next. And I feel like it's more important to see like what they would want to do next and what they have done, before jumping to conclusions.
I just wanted to add that I think this would be the perfect situation, especially depending on how kind of that first half of the conversation goes. If this is something that the patient perhaps is experiencing a lot of great difficulty with, my follow-up questions would really want to go into the chronicity of the symptoms and how often these episodes are happening. Because at least in the patient population that I've worked with in medical school, so many patients go undiagnosed, undertreated, and quite frankly, never have these conversations. And so even if this encounter happened 10 years ago, she may have been living with pretty severe trauma-related symptoms that no one simply bothered to ask or diagnosed. And she could benefit from therapy and medication if she hasn't already gotten it.
You guys are awesome, and thanks for bringing up the video again, because I think it did demonstrate a great skill and an important skill, especially when we're giving individuals resources, is asking the patient. Specifically in the domestic violence and IPV world, sometimes it's not safe for individuals to bring resources back with them to the home. So always, asking the patient, as patients are the experts on their own survival, kind of, would you be interested in, maybe in this case, would you be interested in talking to a social worker about these symptoms, or have you in the past? Or would you be interested in any resources? I do want to zoom in on the micro skill of this case, which is responding to a disclosure of trauma. And I want to present you guys with a framework that I find very helpful. So in my clinical work as an emergency physician, I often find myself in a space where it is not clinically appropriate for me to really get into further details about a patient's traumatic history. Maybe I'm caring for them in the hallway, or they are too critically ill, or we just don't have the time and space. As you all are, many of you are interested in psychiatry, you may very well be the people who provide that kind of end game trauma focused therapy, and you will have the clinical time and space. But in your training, you will also pass through environments where it is not clinically appropriate to dive into all the details of what has happened to someone. It can be traumatic for the patient to retell that experience as they relive it. It can be traumatic for you as a provider to hear and hold all of those stories. So this is the initial framework I will present. Sometimes, for example, when we think about the emergency department, and maybe the patient shares something that's, maybe they start going into a lot of detail, as sometimes patients will do. Sometimes actually the most important clinical skill is to contain what the patient is sharing. And this skill of containment is well described in both the social work and psychiatry literature. And that is, we're acknowledging that it's not always the appropriate time and place to get into all the details. As we said, it's harmful for patients and providers, for patients to constantly retell this story. So if you find yourself, in your career, you're in one of these situations, or maybe it's a 15-minute primary care visit, and you just don't have the time and space to give the patient's story justice, we can say something like, I'm so sorry you went through that. This information helps me to understand how to best care for you, but we don't have to go into all the details today. If, for example, the patient, in this case, is sharing something that we think there's maybe ongoing safety concerns, this would be a time where, even maybe if I was in the emergency department and we didn't have time and space to go into all the details, it's still an appropriate time for me to explore and to ask some follow-up questions. So this framework's really for if we're not doing trauma-focused therapy and we're practicing just that universal trauma-informed precaution. When we're exploring, we're trying to figure out if there's any immediate patient safety concerns. So I think about violence in the home, there's children in the home. So we're asking the patient some of those safety follow-up questions. And sometimes it's as simple as, do you have any concerns for your safety? Or if I was to discharge you and send you home tonight, would you be safe? If there's no safety concerns, we can offer resources collaborating with the patients, like talking to social work, or some hospitals have appropriate related support groups or IPV resources. There are a couple, and this is not an exhaustive list of mandated reporting, but I just wanted to flag for us, some acute safety concerns that we might have are intimate partner violence. If we're thinking that this patient's symptoms are distressing enough that they may be suicidal or homicidal. And then there's a couple protected groups. This varies if you're in the US, state by state, but generally, if there's violence in a home, we are mandated reporters if there are children in the home, minors under the age of 18, those over the age of 65, and those with disability. Questions about that framework in responding to disclosures of trauma?
Feel free to utilize the chat as well if that's easier. Something I'll note in the meantime is that I think it's really powerful to be able to make the statement that you made, Dr. Brown, about even if right then isn't the time, that you are still emphasizing that what the patient shared was meaningful and that there was space for them to either, share maybe not all of it right then, but that I hear you, I see you. I love what you mentioned, like to hear and hold, right? Like you had mentioned that as far as it might be a lot for us as clinicians, but I think also to note that I hear and hold the sensitive information that you're sharing with me and the, how sacred that is. And let's have XYZ time to circle back if we can't do it here. I think that is really powerful. Curious if anyone else has any thoughts.
I have a question, and Donnie, I love what you said. I really like the contain option. When I was in MS3, I didn't have enough knowledge, and so I would often do contain because I didn't want people to tell me their trauma and have it be helpful. But my question is, like, when you do contain as a physician, like, do you write in your note something about their trauma, or how do you like? Is there a way to like kind of say like, oh, we don't have time for it now, but let the next provider know that this is something that they should look into?
Yeah, then I generally will. I guess it kind of depends. If I think it's related to what's going on clinically, where often the vast majority of the time it is, I usually will write something in my note, fairly generic though, like without getting into any of the details, especially since everything's open notes, patient can read their own note. All providers can read the patient's note, unless you kind of lock it and make it confidential. So sometimes I'll say, if it was this palpitations case, I might say like, patient shared, she first noticed the palpitations when reminded of an unhealthy or abusive relationship with her ex-husband. And then it signals to the next provider that I think that might be contributing. It might be something to further explore. I'm just trying to think of other scenarios. Patients tell me every single shift I work in the emergency department about some of their adverse childhood experiences. And maybe this is some personal reflection. There's probably a better way for me to document and include it because the more childhood adversity someone's sharing, they tend to be some of our sicker and really complex patients. And sometimes patients that are challenging for our care teams to help and navigate their care. So there probably is a way to document, when taking the history, just something generic, like patient shares a history of extensive childhood adversity.
That makes sense. Thank you.
Yeah, of course. No, I'm reflecting on my own practice too.
I have a quick follow-up question to that, actually. I love your question, Maddie. I'm wondering, like, I understand that clinical notes are really not maybe a space for self-reflection or like, like you're wanting to get right quick to the point in a way, but also give enough information where that's relevant. And in this case, like you're mentioning, this is extremely relevant. And no matter whether it's a psych, eval, or we're in the emergency department or we're in XYZ, that's the culture we're hoping to promote, right? That it is pertinent to physical symptomology, no matter where you're seeing it. Is a clinical note ever a space to also add a line like that? Like, okay, their patient is sharing, extensive ACEs, you know, essentially that you have an inclination that there might be a greater link there, but you're looking for follow-up. Like, is a clinical note a safe place essentially to write more things like that? Or do you just need to have a very, I imagine, very succinct, I don't know
Well, here's
the
the
word
funny
I was going to say.
tribal medicine is so tribal. If anyone who is psychiatry minded read my documentation, it would seem like I'm just writing a sentence about each patient. So the emergency medicine notes are just very different. And it's a very different specialty. We're not a diagnostic specialty, so we're really just trying to rule out life threats. But I do encounter people with palpitations, with belly pain, especially individuals who have had multiple negative workups for things. I will do a little bit of trauma inquiry or ask what's going on in their life or ask what's going on when they notice these symptoms instead of having them get, a CAT scan every month. That radiation and expense all adds up. So I do think in every single specialty, as you're ruling out other, organic medical things that are going on, there's a space to document to other providers to say whether it's ACEs or significant anxiety. There's a space to document that to say you think it might be contributing, and there's space to counsel patients. So I have come to the end of a lot of negative workups and told a patient, I've crossed everything life-threatening off the list. And I tell them stuff like stress can do crazy things to your body. It can give you headaches, stomach aches, make you vomit, make your blood pressure high. I think that might be contributing to what you have going on. And then encourage them to follow up if they have an outpatient provider they trust. But I certainly think there's place to both document and counsel patients on, we're really trying to educate them on like the effects of stress and trauma.
Thank you so much. That was very helpful.
All right, you guys are awesome. I want to get to case 2 because it gets at different communication things. So for case 2, we're going to meet Chris, the 25-year-old gentleman who had alcohol use disorder, which is now in remission. But while he was actively using alcohol, had many bouts of pancreatitis and has developed pretty severe chronic pain after all those bouts of pancreatitis. He comes into the emergency room one evening in severe pain in the epigastric region, classic for one of his flares of pancreatitis. He's extremely uncomfortable when you meet him. When you're doing a chart review, you see that he's had multiple admissions for this issue. And some individuals have started to document that they think there's some drug-seeking behavior going on in Chris's case. Right off the bat, when you introduce yourself to him, he hits you with, so am I going to get any pain relief, or are you just going to treat me like all those other doctors, like a drug addict? So the questions for us to consider, I guess first, probably even before you think about responding, is considering where Chris might be on his window of tolerance and where you might be on your own. Then think about how you might respond to him. And I'd love to hear folks' thought of how Chris's previous interactions with healthcare are impacting what's going on tonight.
I think,
And for this,
oh, sorry.
go ahead.
Go ahead. No, I was just gonna say this is a very interesting case that delves a lot into the stigma that a lot of patients that have to use opioids for a lot of pain have to deal with, because there's been this societal problem where this topic of opioid epidemic in the US, and then the response to that being like cutting, almost like not trying to give opioids at all. And a lot of those patients are, chronic pancreatitis is really painful. And it is a diagnosis that merits that. And one of the, I think, directives that as doctors we have is to minimize pain as much as we can. And of course, with this patient, his past experiences of doctors may be reluctant due to all this stigma around it to just not give this pain medication. Well, that's of course going to impact his self-esteem, the way he sees healthcare, the way he sees doctors. So it is a really interesting case. I think it would be first try to reassure the patient that this is not the experience we're trying to give him, and reassure him that we understand this is a very painful condition and that his pain is very, of course, real.
Awesome. I think you hit on so many great themes there. I'll hold my comments back in case anyone else has a follow-up comment.
Yeah, just going off that, like he's clearly frustrated, and his frustration is obviously justified because in any other case scenario, when someone comes to the emergency department, they don't have to justify or try to convince the physician of their pain. Whereas in his case, and a lot of other people with substance use disorders, they often have to, like, it's almost like they have, like, they're arguing their own case, like they have to convince you that they're actually in pain. And if you have to do that even more than once, yeah, I'm gonna be like, who wouldn't get frustrated with providers and just assume that they're gonna think the worst? Um, and at the end of the day, providers aren't like we're not trying to teach them a lesson. Like you said, Monica, our goal here is just to ease the pain, help them with their pain. That should always be the priority.
Rahi, I love what you said, and same with you, Monica. I wanted to kind of take the role of the provider and like my window of tolerance. And when I worked in the ED, like I want to go into addiction psych. I really love working with people with addictions. But when I was in the ED, it can get frustrating because you're treating these people with pancreatitis and I don't know, other symptoms of their disease, and you're treating the symptoms of their disease, not the root of their disease. And so it's a burnout on the provider. I completely understand like why the patient is frustrated, and I also can understand how providers can get kind of worn down as well.
I love that you bring up, both sides of the interaction. And I would love to tell you guys that I am always 100% trauma informed on every clinical shift, but there are really hard clinical shifts. I get sleep deprived, especially as a resident when I was working a lot. And this is why I love trauma informed care so much because it kind of stops me. So when I get hit with a patient coming at me with a lot of emotion, trauma informed care and TIC reminds me to say why. What's happened to this guy that now he is upset with me when I just have walked up to his stretcher. And he shares that without me really having to ask anything. Just in a few sentences, he shares, how much discrimination and, potentially how much trauma has been inflicted on him just by our medical system. So in that way, I find it really helpful because it makes me pause. I think, where am I? I haven't had a snack. I haven't had a pee break. I'm not in the best spot. And this patient clearly isn't either. So I can take a beat before I respond and engage. I heard someone mention kind of an initial response, so I'll go off of there. It's simple language. These responses aren't really complicated, but just acknowledging that this patient has been through a lot and potentially at the hands and words of some of our colleagues. So just saying something like, I'm sorry that happened to you. No one deserves to be treated like that. Another strategy that I find really effective when patients have experienced discrimination or have been just unhappy with their care in some way is finding out what the patient most wants and aligning with them on that goal, collaborating with them. All of you guys mentioned we're trying to take care of Chris's pain. And so I do that. I focus in on what the patient's main concern is. And I say, and this usually really helps me de-escalate a situation. I want to work with you. I want to treat your pain. And patients are the experts on their own body. Is there something that's worked well for your pain in the past? If he tells me 6 milligrams of IV ketamine, I will go back to my computer and I will put in that order because I know that this patient needs pain treatment. Questions or more comments on case 2?
I'm sure others felt this way, but I just got chills when you said that if the patient said that you would go in and put that order, because I feel that oftentimes, unfortunately, the space can be, dehumanizing for patients, like we're seeing here in this case. And I think I just want to note that this concept has been reoccurring this evening of agency, and how a big part of trauma-informed care, regardless of specialty, is recognizing that agency belongs to the patient, and not, not pretending to be the expert in someone else's life. So that's been really resonating with me, but curious for others.
I guess I just wanted to add that I thought it was a very interesting comment to see also the side of the provider, because of course uh, a lot of providers in the medical system sometimes they're burnout, there's a lot of work, excess workload. It is pretty hard sometimes to pause and be in that empathetic side, even if you are an empathetic person, to have all that workload on top of you, not sleeping, and just pause and be that person, right? And I think also the system sometimes makes you have to practice some kind of defensive medicine. So sometimes even if you want to give that treatment to that patient, you know that's the best option, sometimes there are other factors around you that can make you reluctant to do that. I don't know if Dr. Brown, if you have experienced something like that, especially with pain management in patients.
Yeah, the beautiful thing about being an attending now is I just have fewer and fewer bosses. So I can, if a patient wants something, I can usually order it. But certainly, and also the inconsistency. This patient may get myself as a provider who's like, if you're giving me the answer, I'm taking the easy road and I'm going to listen. Um, but there might be another provider who has their way of doing things and is less interested in that collaboration. Um, so I think there's so many system factors, and that the time pressures and demands of, especially a specialty like emergency medicine, it's really about patients per hour. And I don't mean to sound utilitarian with that, but if there's a sick person waiting for you in the waiting room and you're spending too long with each patient, you can do real harm. So there's certainly time pressure, primary care, the short 10, 15-minute follow-up slots with patients. So as much as we can, working with patients within those constraints can be really challenging. But TIC makes it more rewarding. I'm going to shift our gears a little bit and move into trauma-informed physical exam. This one I don't have cases for, but there will be like a little quiz section at the end. So a little bit less participation. You guys were awesome with the discussion. I'll try and block off some time at the end for questions too. So when I think about physical exam, I think that there's two key parts. There's what we do in terms of our physical touch and the exam maneuvers, but I think 80% is what we say and how we coach patients through it. So actually the trauma-informed physical exam, maybe this is a misnomer, a faux me, we're going to go into a little bit more communication. These next couple slides are adapted from Dr. Sadie Alessio's, her paper on a novel approach to trauma-informed physical exam. She's now a good friend and colleague. These next couple of slides changed my life. These are some of the most simple, practical things you guys can take away that will make a difference. This one right here. The removing of your and saying the helps to make our language so much more neutral and clinical. It's more professional and it's less personal. When we say the in front of a body part, we're talking about the anatomic body part that we're examining for medical reasons. Whereas when we say your, it really personalizes it for a patient. So this example is not meant to be crass, but listen to the difference. If I'm doing a genitourinary exam for a patient and I say, now I want to look at your penis versus I will now inspect the penis. Again, in that second example, it is neutral, it is clinical, it is a medical exam, and that is understood by the patient. You know, instead of using any casual colloquial terms, we're just trying to keep things as neutral as possible. In addition, instead of it calling anything the bed, I always say to a patient, I usually use stretcher because I'm in the emergency department, so that's what we've got. You can also use exam table, but bed, again, it just has personal connotations. This last one, you know, there's also some language that we use that just, it becomes part of that second language of medicine. Provocative tests to a patient can sound very different than when we just, what we mean, you know, we're trying to test for MCL laxity, just say additional tests. Instead of saying before we perform an exam maneuver, I want to do something, I'm going to. So you remove that want, that any element of desire from there. Instead of saying look at, we say inspect. Instead of feel or touch, which are again very personal, we say examine or evaluate. This one goes back to something I mentioned when we showed the window of tolerance graphic. So sometimes we give people medications and they're going to put them off to sleep, or you know, we're trying to help a patient relax. This one's just a reminder that we have no idea what patients find relaxing, soothing, or potentially activating. So instead of telling someone to pretend they're at the beach, maybe something horrible and traumatic happened to them at the beach. We just say, you know, maybe we walk them through a grounding exercise or say something like, some find it helpful to take a deep and relaxing breath. We should talk about the word relax. And I don't think anyone in the history of humanity has ever relaxed when instructed to relax. So instead, you may say something like, allow the knees to relax. Or when I'm doing a pelvic exam, I'll say something like, allow the knees to fall to the side, allow them to, you know, your knees to touch the sides of the stretcher or the railings. That second example also highlights a patient's autonomy to control their own body parts. Because oftentimes, you know, in individuals who have survived trauma, a main part of the traumatic experience is a loss of control and autonomy. Here's another one. This is up there with the your and the. Remove for me from any of your instructions. It's just this commonly used like verbal tick or add-on that again just makes things really personal. So again, I don't choose any of these examples to be crass, but to highlight how it can come across to patients. So instead of saying something like, hop up on the bed for me, you can say something like, have a seat on the stretcher or exam table, or take off your shirt for me. You know, here's a gown that you can change into. It's best just to avoid the phrase altogether. When we think about, you know, performing a thyroid exam, instead of saying, swallow for me, say, I'm going to place the hands on the neck to examine the thyroid. We're giving context. When you can, please swallow. No your, no for me. All right, I'm going to shift us into some visual representations. And there'll be two pictures on the slide. One will be a trauma-informed approach, and one will be more like standard of care. What I want for you guys to do is to tell me which image is trauma-informed and why you think so. And I got this wrong the first time I did these as well.
Continue to feel free to utilize the chat. Oh, I thought somebody did. Okay.
You can also just put in the chat right or left. Last time I gave this lecture, then I messed up my right and left. And Danya had to correct me.
Oh, we have Monica in the chat saying trauma informed is the right.
Yeah, and this is why this lecture has been so really life-changing for me, because you see how subtle it is. You know, this isn't adding length of stay, and you know, we're not introducing anything new. The provider is shifting her stance by, you know, in this maybe a foot. But in the photo on the right, she's at the patient's side within the patient's peripheral view, can still access all the posterior lung fields with the stethoscope. Um, you still get all the same data for your exam, but in this way, the patient can see what you're doing at all times. And so they're not potentially activated or triggered by having someone behind them who they can't see what they're doing, and they can't see when they're about to be touched. You'll also see that she has a hand on the patient's shoulder, which helps the patient to understand where the provider is in space as well. All right, same exercise, right or left?
We have Abdullah and Madeline in the chat saying that the right feels more trauma informed.
Awesome. Yeah, the thyroid exam comes up often as we are traditionally taught this posterior method, where in the photo on the left, this is the traditional thyroid exam, you are behind the patient with two hands wrapped fully around the patient's neck. This can evoke strangulation, which is one of the most underreported forms of IPV. So if you prefer a posterior approach, one way to alter this is to stand off to the patient's side. So again, you're in their line of sight. And then you'll also see subtly that Dr. Alicio has changed her hand position. So instead of the thumbs wrapping posteriorly around the neck, she's just using, I mean, the information you're getting is from your finger pads on the anterior neck. So we're not wrapping our hands fully around the neck. We went over some of the instructions to use for this exam. You may also choose an anterior thyroid approach where you take a single hand anteriorly over the thyroid. That's been studied to be slightly less sensitive. So presented here is a way that you can modify the posterior approach to the thyroid. All right, we have one here demonstrating the pelvic exam. Right or left?
We're hearing left in the chat from many participants, Madeline, Monica, Abdullah. Wondering why you guys feel so, Omnia? Thank you. What stands out?
I would say on the left, the patient is able to see the provider actually on eyesight.
Exactly. The patient can see what's going on here, as opposed to having them this completely supine position in the image on the right, which is a position really of subordination as well, and it's hard to see what's going on.
Just wanting to highlight that that was caught by a few people. So Omnia also mentioned patient side, and Abdullah mentioned that the bed was inclined, which you just shared too. So yes.
Awesome. This one's subtle. Right or left?
We're seeing left in the chat from Abdullah. Oh, we're taking our time with this one, guys. It's tricky. Huh? Hearing right from others, Rahi, Madeline, and Omnia. This is a good one. Anyone have any thoughts on why they chose what they chose?
I'm not really sure, but I saw the green check mark, so I feel more confident. But I
Gave
think
it
for
away.
the one on the right, I think maybe instead of like encroaching on her personal space on the left one, you're asking the patient to move the arm to the left, maybe. So I'm guessing maybe that's it. I'm not quite sure though.
So full disclosure, the first time I saw this presentation, I didn't understand and I had to like read the comments afterwards. Um, and this is something I was 100% guilty of before seeing these images. So in the image on the right, if you're taking a patient's pulse and they have their hands lying in their lap, you're reaching into the patient's personal space, and also their hand resting in their lap is pretty close to their groin region. So instead, now what I tell patients is I just say, I'm going to take pulses in both wrists, and most patients reach their hands out. And in that way, again, for most patients, that might not be activating, but there certainly are some who would be much more comfortable having their pulse taken when their wrist is, physically away from their midline and certainly out of their lap and groin. For this one, I don't have an opposite photo, but in terms of respecting personal space, just to be conscious of our presence in the room, Dr. Alessio actually works in the VA and practices with a lot of individuals with PTSD and combat trauma. So in her patient population, blocking an exit can be extremely activating for a patient. That being said, as providers, we should always be conscious of our own safety and not allow someone else to block the exit for us. But to just be aware that if anyone does not have access to the exit, either patient or provider, it can be potentially activating.
Ron,
Oh, go ahead.
I apologize for interrupting you. We have a quick question. I feel
Yeah,
like
absolutely.
oh, he mentioned would the LEAP interview be appropriate in this setting? Maybe we can go on a little bit about that, Abdullah.
Yeah, hi. Can I unmute, please?
Yes.
Yeah, absolutely.
Oh, okay, thank you. So, LEAP interview technique or method, I'm not sure if you're familiar with it.
I'm not.
Okay, so it's basically a interview method done by Dr. Javier Amador, I believe that's how you
Okay.
pronounce it. And he's part of the authors who helped in the DSM-5. So it's an interview method to interview patients who are psychotic, specifically schizophrenics, when they're being very resistant to adhering to medications. So I'm not sure if it's applicable in this setting, but because it had this part of empathy, listening, agreeing to disagree, and whatnot, so I thought maybe it could be applicable. I'm not sure.
I'm Googling it on the side. In my clinical practice, I'm not as, versed in interviewing psychotic patients other than determining that they're probably psychotic and needing psychiatry. But it sounds like there's certainly overlapping elements. Uh, I will say that the skills introduced here can really be used in any clinical interaction. So whether it's with your psychiatry patients who maybe you're not aware have a history of trauma, or if it's at a part of your training where you're seeing a more generalized patient population, these skills are pretty broadly applicable. But it sounds like there's certainly a lot of overlapping elements and themes there.
Okay, great. Thank you.
Mm-hmm. All right, I want to move us on to our last micro skill of the night, just to make sure we have some time for questions as well. So sometimes, despite our best efforts, maybe we did everything trauma informed from the start, a patient may still be activated or triggered. I find that physical exam is typically when this happens anecdotally. I think when you introduce physical touch, if someone's already out struggling with their window of tolerance, this can really be the time where patients get activated. So someone mentioned earlier breathing techniques, so I do want to introduce them formally as grounding exercises, which if we think visually, I'm going to flip back to the window of tolerance. When I think about a grounding exercise, I think about either someone who is activated and I'm trying to bring them back down to earth and that into the window of tolerance, or I think about someone who's kind of shutting down and I'm trying to put some ground beneath their feet again. Grounding exercises are very simple. This one on the left is square breathing, where you inhale for a count of 1, 2, 3, 4. You hold that breath, 2, 3, 4. You exhale, 2, 3, 4, and hold again, 2, 3, 4. I love this one because I do it myself. If I'm leading a resuscitation or I have to do a high stakes procedure, or if I'm just at the end of my rope on a clinical shift, I can do this and nobody knows. It's also something that's really easy to walk patients through and teach them. And also, no one has to know that a patient's doing this exercise. So keep square breathing in your back pocket. It's very, very straightforward. There's other grounding techniques like 5, 4, 3, 2, 1. This one's a little, I like it if someone's maybe more hypo-aroused and shutting down because it engages them a little bit more. So you ask the patient to name 5 things they can see, 4 things they can touch, 3 they can hear, 2 things they can smell, and 1 they can taste. There's tons of other grounding exercises and techniques out there. These are just 2 of my favorite because they're pretty straightforward. The last slide I'll end on is this paradigm of vicarious healing and vicarious trauma. I think it's really easy in trauma talks to get bogged down with all the horrible things that can happen to our patients. So in the same way we can kind of live with that vicarious trauma, we can also heal with patients. When I see a patient do something really brave, like come back to the emergency room after they've left the hospital AMA, or someone shares with me that they've, been 10 years sober and that's something they're really proud of. I love to celebrate with patients, and I think it's that vicarious healing that keeps me so invested in TIC and really helps with, my own burnout and my own clinical work. All right, we've got some time and space for questions. You guys, please feel free to take down, this is my professional email. Happy to answer any additional questions. If you're really inspired by this work, I would love to collaborate. I'm also part of a national collaborative that does trauma-informed care, healthcare education, and research. And that's the little link down there to the TICER website, which has our contact information and some of the projects that we've done. I'm going to stop my screen share so I can actually get back in the game here.
Thank you so much. Thank you so, so much. I could go on forever, but I'm going to just thank you right now for the sake of time and say that I'm sure I don't speak only for myself and Madeline, who I know will say something as well, for how informative but also just touching this discussion is, how impactful it's going to be for our practice. So thank you for your time, Dr. Brown, truly. And yes, of course, I'll give the floor away.
I just wanted to say thank you as well, Dr. Brown. It's so encouraging to see physicians outside of psychiatry taking interest in trauma-informed care, and I think it can go honestly so much further when patients get it from multiple disciplines. So, so just thank you for sharing this with us. I really appreciate it.
It's probably my number one used clinical skill in my day-to-day ED shift. And when I, the more emergency physicians that I talk to about it, like, I think it's really found the right time. People are really excited about it across a multitude of specialties.
please feel free to insert a question in the chat if you have one, and no worries if not, of course. Had a lot of discussion during, so maybe.
Oh, thank you, Dr. Brown, for your talk and your time. That was very informative, and I share the sentiment with my peers that it's really nice to see doctors other than in psychiatry being so invested in trauma-informed care. I guess my only brief question, I think you mentioned working also and seeing patients that have been victims of IPV. And some of these techniques are also for those patients. Is there also any specific techniques maybe for victims of sexual violence or something that you do differently for them?
I think a lot of the initial precautions are still the same. In the emergency department, we do see a lot of individuals who come in, maybe kind of directly after a traumatic event, and our treatment for them, we've really tried to protocolize. So, something I might do differently if I know a patient is coming in after an acute traumatic experience. Instead of, for example, patients are triaged and maybe the resident goes in and then the attending and then the nurse and the patient tells a story 4 times, I will get the entire team together and I will tell the patient, this is your entire care team, and I'll introduce everyone and I will tell them that, we're all here together so that we only have to tell the story 1 time. And then I also signal to the patient up front, they can share as many details as they feel willing to, and any follow-up question that I ask is only to ensure that we're keeping them safe medically. And then my documentation for individuals who come in either directly after sexual assault or violence is extremely different. Because our charts will often end up in court. And so then you layer on the American legal system and you layer on how trauma impacts memory. And so I try to document really actually as little as possible about the event, so that if a patient gives testimony later, there's no conflicting data in my chart. So there's actually a very different way to document that I teach our residents about too.
Thank you, doctor. That was very insightful.
Yeah, of course.
Abdullah, yes, please.
Yeah, thank you guys. Thank you so much, doctor, and thank you to everyone who's organizing this. I just have one question, if I may.
Sure.
So, have you read anything related to like psychedelic assisted psychotherapy or like psilocybin in the generally like in treating trauma or like sexual abuse?
Only very generally, in that it's, being studied as a therapy, but from the emergency room, I would just be referring individuals to psychiatry. So maybe I'm aware that it's something that they are doing outpatient, but much less in depth than maybe some of your other psychiatry mentors.
Great. And you mentioned other psychiatry mentors. Could you maybe give me a name or two?
Oh, of my own, or are you interested in connecting with some individuals?
No, I'm interested in connecting with some individuals in psychiatry. But I'll be totally honest, I'm planning on going to Canada to pursue psychiatry residency, not the States, but it's within my options.
I'm not aware of anyone specifically working in that field that I know personally as a colleague.
Okay, that's fine. Thank you.
Mm-hmm.
Abdullah, we'll be sure to, it was great questions. And so we'll be sure to follow up with you too with a few other of our psychiatry mentor speakers. But thank you for the question.
Thank you so much, Dunya.
Of course. Anyone else? Questions, thoughts, reflections, feelings?
Just because you're an emergency room doctor, I'm curious, like, is there anything, I just matched psychiatry, is there anything you wish like psychiatrists knew, or anything that you would want to tell a psychiatry resident to keep in mind about the ED, or just in general?
Yeah, I think emergency medicine is like the funny, ugly stepchild of medicine, where everyone loves to dunk on emergency medicine. I think, oftentimes it gets a bad rap of like, we're just trying to see all the patients. So I think as much as individuals can actually see what clinical care looks like in an emergency room, and like we have an excellent relationship with our consult liaison psychiatry in the ER. But just it's all the challenges of US healthcare are really magnified in the emergency department. So we have pretty critical staffing shortages. The volume of patients we're required to care for is driving a lot of people out of our specialty. And I think the hardest part for emergency physicians is our really like code switching. Like you come out of a room in which maybe you just had to do like a pediatric cardiac arrest, and then to still have empathy for the person who's had palpitations for a year. And you know that they're probably fine, but it's extremely distressing to them. That's probably one of the hardest job parts of emergency medicine. And a lot of other specialties have a lot of knowledge about their thing. And so they can critique our care. And the emergency room is always just kind of trying to build the plane as it flies and give everyone the best care we can with what we've got. That's probably what I'd like people to know.
Oh yeah, that's beautifully said. And my experience on my EM rotation was, wow, I'm so thankful for these people because they know everything. Yeah, I couldn't do it, to be honest. So I'm really, really appreciative of you. Thank you.
I couldn't do psychiatry. I love our psychiatry colleagues, but what you guys do is incredible.
Any other closing thoughts or questions? Well, how does one transition from this into the rest of the evening? I don't know, but we just want to thank you so much again, Dr. Brown, for leading us through something that we don't ever really get a chance to talk about. And so very grateful for both everyone here. I want to thank everyone, for your participation. This was a really active group, and it was really, really refreshing. And also to those who will watch and who will benefit from this, both AMSA members, as maybe they whatever specialty their heart so desires, and also our psych, science students as well. I think we'll have a great mix of students that will have an opportunity to hear from you. So thank you for what you bring into the world, and we hope to see you again soon.
Awesome. Thanks, everyone. Have a good night.
Have a good night, all.
Thank you.
Recording now.